Good afternoon, everyone. I would like to welcome you to week 3 of our 16th annual TELUS Health Conference, our virtual edition. I'm Jason Kennedy. I'm a Director of Health Business Consulting with the Health Benefit Management team here at TELUS Health. And today I have the honor of being the MC for this webinar. Before we begin, as per usual, I'd like to take an opportunity to thank our sponsors and also our insurer partners from our steering committee, in particular Canada Life, Equitable Life, La Capitale, Sun Life Financial, and Union B Insurance for helping make this virtual conference possible. We have an insightful webinar panel and discussion that awaits here in a few moments, but some general housekeeping for everyone. We've got great attendance today, climbing from the past 2 webinars. Today we're at over projected 900 participants on the webinar today, a truly incredible turnout. But in order to ensure optimal video quality, we'd ask that you turn off your camera. Your audio should already be muted. And separately, in this case, we'll be turning off slides once we get to the presenters. At that point, you'll have the option of using grid view to see the panel for optimal viewing. So suggest you do that. As per past webinars, we have a chat function available, and we encourage you to virtually network by using it. It's located at the bottom of this window here. And that chat function also allows you to ask questions at any time during the presentation. Just direct that to the panelists, and we'll queue them up. Alternatively, at the end of the presentation, you can also ask questions through the phone. We'll give directions on how to do that. If you do happen to have any technical difficulties with the WebEx, please email us at telushealth@telus.com or send a message to my colleague, Susie Kim, via the chat function, and we'll do our best to address these questions. In this case, we'll be recording this webinar and will be hosted on our Health Benefits Hub in a few days. To be notified, simply subscribe to the mailing list. And for those of you who use Twitter, please use the hashtag HealthBenefitsTrends to participate in the conversation. And of course, because we want to know how to get better at these webinars, you'll be invited to fill out a 3-minute survey at the conclusion of today's session. We'd love to get your feedback on what we did well and what we can improve on. Please help us get better at this. CE credits are also going to be available this year, but function a little bit differently. In this case, the participant list from this webinar will be submitted along with the webinar material for CE credits. Please give us a few weeks, though, to get back to you on this. And without further ado, the people you've come to see today, I'd like to introduce you to today's moderator and panelists. We're excited to have some of Canada's highly respected, sought-after thought leaders to join us today. We have Michael Dingle, leader and advisory partner of PwC Canada, who will help us steer the discussion this afternoon. And on our panel, we have Dr. Alexandra Greenhill, the founder, CEO, and CMO of Care Team Technologies, Dr. Sasha Bhatia, Chief Medical Innovation Officer at Women's College Hospital, and Dan Palou, a General Manager at Acura Health by TELUS Health. And without further ado, over to you, Michael.
Thank you very much, Jason. Happy to be here, and good afternoon to our audience in the East. Good morning to those on the West Coast. As Jason said, I'm Michael Dingle, advisory partner at PwC, and it's my pleasure to be here to moderate today. Without further ado, I'm going to ask our panelists to introduce themselves. We'll start with Dr. Greenhill, and then move to Dr. Bhatia, and then to Mr. Dan Palou. Alex, please.
So I'm excited to participate. I've been part of the forefront of computerizing health in hospitals and clinics, and now going to the virtual space across Canada. Learned a lot from global initiatives, and working on creating a virtual healthcare collaboration layer with care team and partners, where patients and physicians can connect across organizations as they need to in order to ensure the best outcomes and experiences. Thank you.
Thank you, Alex. To Sasha, please.
Hi, Sasha Bhatia. I'm Chief Medical Innovation Officer at Women's College Hospital, which is, a unique hospital in Toronto, steeped in history. It's a fully ambulatory academic Health Sciences Center, and by ambulatory, we have no inpatient beds and no emergency room. And as a result, we had to completely reimagine the business model and the way that we deliver care. So today, our aim is to be one of Canada's first completely virtual hospitals, and we can talk about that as the presentation goes on.
Good. We'll look forward to that. Dan, please.
Sure. Very excited to be participating in this panel. Name is Dan Palou, co-founder, co-CEO of Akira Health. I've been involved in healthcare services for over 20 years, virtual care over about 10 years, and I've been operating the Akira platform for a little over 4 years. Akira Health spends most of its time in the primary care and mental health pace of the world. Very excited about all of the progression and advancements that virtual care has made over the last number of years, and definitely over the last 6 to 9 months, and very excited to talk about the developments further here today. So thank you.
Perfect. So let's dive right in. First question will be to you, Alex, and we can see you now, which is good news. Let's start with some definitions. What exactly is virtual care?
Well, that's been the most confusing thing to deal with, because depending on government or physician or patient, it can be anything from the ability to receive a text message, a phone call, do a video visit, or be monitored remotely. And so similar to AI, it's really important to clarify what does the other party mean by that and what is included as opposed to excluded in that definition. All of these things can coexist, and they're relevant in different ways. And so I see a future where we will have the ability to choose what's the right method that's needed. And similar to how this interaction just got better because you can see my body language and visual presentation, there are places and times where even a simple message is more effective when video is involved.
Okay, so then let me, if I can, perhaps to you, Sasha, what is the difference between telemedicine and virtual care? Is telemedicine just the yestertech from which virtual care was born?
So, I think people often think about virtual care, telemedicine, telehealth, e-health based on the technology. And I'm going to say that the way we think about virtual care is really focused on the care part. So it really is about being able to deliver healthcare over space and time. So, traditionally we've had to deliver healthcare in person in real time with a patient in front of us. And virtual care, and notice I haven't spent any time talking about technology, but rather a method of being able to disaggregate time and space from care. So that could be delivering care by email, by text message. It could be delivering a message on the phone. It could be doing a video visit. It could be remote patient monitoring through a wearable. So the technology really is secondary to the actual concept, which is really about the way that we're thinking about delivering care. So virtual care is really a mindset of the way that we're going to be delivering healthcare to our patients.
Okay, very interesting. So now let's move to the current state. We are perhaps suddenly in the future today. I'm thinking of COVID-19 and what seems like a decade of change, particularly in the virtual care landscape in Canada over the past couple of months. Dan, I wonder if I can bring you into the conversation now and say, let's start with what's happened in the virtual care landscape in the last 60 or 75 days.
Yeah, it's a great way to kind of frame the conversation. I would say the biggest kind of headline is virtual care. Instead of 2020, it's really 2030. So frankly, I think it's almost 10 years of advancements that we've made in the last 30 to 60 days. As we all know, healthcare and digital healthcare, especially in highly regulatory regions such as Ontario, does not tend to move at the pace of Google. So I do think that it's literally accelerated the adoption by about 10 years. So I think that is fantastic. And I think it's really two things. If you look at it from the lens of plan sponsors, which is where the Akira business spends most of its time within the employer market and plan sponsors, I think, frankly, gave plan sponsors a license or an excuse to adopt virtual care. There were a lot of people who were looking at it, a lot of people who were thinking about it. It made a ton of sense. And then I think what's happened in the last 2 to 3 months is it gave plan sponsors the license, the ease to be able to adopt it. So we've obviously seen tremendous adoption in the last 2 months for the service. That's on the plan sponsor side. On the patient or consumer side, I think it's had as big of a revelatory effect as the plan sponsor side, because now what we're seeing is people accessing virtual care services, and they never have done that before. And similar to the way Sasha has talked about it, it's not the technology, it's the experience, and it's the time and space and the experience that you would have with your provider. So one thing I always like to say is, okay, when was the first time you had your virtual care? When's the first time you had for us, a primary care appointment? And to what Alex and Sasha were saying earlier, about 50% of our virtual care interactions are actually text-based. They're not actually video. So to your point about telemedicine, people may have thought 10 years ago telemedicine was a video visit. Ours, we think about what is the experience, what is the interaction. So what I'd like to tell people is, okay, when's the first time you got your email? Most people know which year was the first time they actually had an email address, and you can kind of think about it. And then I also ask them, when's the first time you had your first virtual care appointment? And what we find is once people use virtual care, the first time, whatever experience it is, text, video, access to a health record, whatever it is, once you use it once, you use it a lot more. So we can go into our utilization statistics a little bit in general later, but that's the biggest thing we find. Once you use it once, you use it a lot as an individual consumer, and then your adoption it really is almost logarithmic in terms of your use. And once you do that, there's a whole host of services and offerings and experiences you can have with either an extended care team or their family members. So I think that's the biggest thing that we have found is it's accelerated by 10 years, and both on the plan sponsor and the individual patient side, it's accelerated the comfort level of accessing virtual healthcare services.
Okay, but let me, if I can, then I want to dive into that. And Alex, this is to you. So I think the answer to the question for me is my first virtual care visit was in 2013. But Alex, what has this pandemic done for the acceleration of virtualization of care in Canada that I'll say the traditional market forces have been unable to do heretofore?
Well, I mean, great questions, and I was eager to follow on to Dan's comments about this. And sort of, while it's true that once patients and physicians experience it, they want to continue doing it, there was a lot of fears as to, will this be awkward? Will this be effective? How will this work on the relationship? And they realized that all of these fears were unfounded. The utilization doesn't go through the roof like a lot of decision makers are afraid. This essentially makes it a better visit that's more timely relative to something that may have taken longer to deal with and delayed and caused more complications. And so people don't call their doctor all the time just because they can. They call them more appropriately, and this avoids more severe conditions. And that's an important message to share. The interesting thing is that we've acted as if this is impossible. And the current crisis has made that no longer an excuse that people could rely on. And the status quo was just familiar and easy, and people weren't even willing to try. And the COVID pandemic has forced them to try. And their discovery is that it's not the end of the world, that this actually works well. And the combination of these things with in-person visits is key, and that the way forward is we no longer can put patients side by side in a waiting room anywhere, in a primary care clinic or specialty care clinic, and therefore being able to triage people before a visit by using some form of, to Dr. Bhatia's point, It doesn't have to be video, it doesn't have to be synchronous. It could be a pre-screening tool that allows you to identify, can this person safely be seen face-to-face? But the more important question is, should they? Should they get into a car and drive and wait when they can just do it over video or phone?
Okay, so to Sasha then, as I saw someone write on Twitter a couple of weeks ago, when this is over, they would like their children to go back to school, but they would like to continue to see their doctor over the internet. Sasha, will this endure on the other side? Let's imagine a post-vaccine time. Will the levels of virtualization remain, or will we see a retrenching to where we were?
That's the multi-billion-dollar question if you've got shares in Zoom or one of those companies. I think so. I don't think that we're going to see what we saw before, which was adoption rates in Canada and even in North America sort of be in the the single to low double-digit percentages of virtual care. If you look at most hospitals and healthcare organizations in North America right now, they're looking at utilization of virtual care, whether it be video, phone calls, or any type of the things we've mentioned, sort of in the 70 to 90% range. I can tell you at Women's College, not published data, but right now we've converted over 90% of our ambulatory specialized medicine visits to virtual. Our mental health service is 100% virtual. So, and we've seen minimal drops in overall volume. So it's not that we're doing a lower volume. We've done massive substitution. What does that mean? I think it means that, now, do I think we're going to stay there? Probably not. Because I do think there is a whole conversation around clinical appropriateness. When do you actually need to physically see somebody in person, for example, to examine them? There's going to be a lot of questions around, what type of modality for what type of condition. Again, this is a whole new area where there needs to be work in. But I think we're in a very different position where we're going to start to see us actually come at this not from the left side of the curve, but from the right side of the curve. So, we're probably going to end up maybe 50% or more in some cases. We're probably not going to sit at 90, but we're probably not going to sit at 10 either.
Okay. So now let's move a little bit to the models of care virtualization. And Dan, this one's for you. We see lots of different models in Canada. I'll name a few. We've got those in the electronic medical record business who have either from the bottom up or the top down applied virtual care technologies to their stack, one. We've got pure virtual care providers who embed, they are a tech-enabled service, I'll say. We have virtual walk-in operators, and we have those that are selling technology purely. Could you comment on your view of how that market will mature? And then, of course, we'd appreciate hearing about Akira's plans in that respect.
Sure, Michael. No problem. Just handing a print off the printer to my 16-year-old daughter as she does her homework. So multitasking here. It's interesting. You could probably use Sasha's analogy of less about the technology and more about the services being offered. So very similar to what occurs in today's world, where plan sponsors or employers provide certain healthcare benefits or services to their employees. They do that right now. They just happen to be adopting some virtual care delivery of that. Very similar to family doctors throughout the country. They've historically always provided physical care in person, primarily related to the fact that their reimbursement system has been fee-for-service, except in certain capitated practices in Ontario where we don't need to see the person in person. So therefore, now that the pandemic has forced them to do that, and you can stand up a virtual care solution embedded within the EMR, they've now been able to provide access to their patients through a virtual channel, not just in person and physical. And then Sasha has already discussed all the great ways within the hospital environment that they're able to virtualize the service. So I just think about it as literally just another way of providing healthcare services to either patients or to employees or to consumers. And it's just, frankly, another delivery channel. That's kind of the easy way of saying it. What the next step is due to the digital, flexible nature of a virtual care service and transporting data, not physically needing to go places, the opportunities are endless going forward as to how you can connect all that data together, which is really, not that we want to get ahead of ourselves here, but that's where the real interest occurs, 2 to 3 years down the road, is how can we now use a little bit more of a flexible platform to be able to connect these different providers of care, because each of the providers of care provide a different service and a different capability.
Okay, well, you brought up an important point, which is the liquidity, or perhaps the historic lack of liquidity of healthcare data. Let's go there for a moment. Alex, I see you nodding because I know you think about this often. What does the virtualization of care do for the promise of interoperability, perhaps, and the promise of one patient and one record?
Well, I'm nodding because sort of having been part of the early wave of telehealth in Canada, you sort of see the future where this is a necessary function. It enables us as Canada to start responding to the needs of remote communities. And how do you provide the same level of service to someone who doesn't live in a major city and have access to the tertiary care specialists in your neighborhood? And so in many places you have a choice where, Denmark or Holland, it's 2 hours drive from one end to the other end of the country. But in Canada, we have to see this as a solution. And the sort of coordination across is a key, so that this is really part of a workflow and doesn't become a series of one-offs that are disconnected and make things even more fragmented. Is important. And the ability to do that, the only way that I see forward is to ask the patient to be the connector. And so the patient provides consent for one organization to access the information that the other organization has about them and creates that liquidity of data, because otherwise we're going to end up with 12 jurisdictions or national platforms that are housed by one organization or the other, and bigger silos but still not connected. One of the things that we've seen with Care Team is in the COVID crisis was the emergence of asks for different platforms by different organizations. So 811 wants technology, the community organizations that do Meals on Wheels and other type of home visits want another type of technology. And so you're seeing this increased number of technologies and providers, and without a centralized source of function. But if you think of all of our services going virtual and physical distancing being here to stay for at least 18 months, if not longer, until we can properly test and develop vaccines, we need to start thinking about how do you put all of them together. And privacy and security rules still exist. Some people have thrown them to the wind and said you can see your patients on FaceTime. I think that that's not the right direction. We have opportunities to create something that's unified, but the only way to fast track that without changing legislation is to ask the patient to authorize it.
Okay, we're going to stay with our doctors for a moment here. And Sasha, this one to you. I'll ask a couple of questions embedded in one. This is about the concept of the clinical requirements here, but also maybe the exam question is this good medicine? And what about continuity of care? And is virtual attachment a thing? Can we delve into that first to Sasha and then to Alex?
Sure. Okay, I'll take them in turn. So one, is this good medicine? And the answer is we don't totally know yet. This is, we've certainly had a number of studies, and there's been a lot of research on virtual care over the years that has certainly not demonstrated worse outcomes. It's certainly demonstrated equivalent outcomes. I think that's important. It hasn't demonstrated adverse events. So I certainly don't think that it's dangerous. And I can certainly say that there has been evidence to suggest that Patients like it more, and providers have liked it under certain circumstances, and it's had improvements in adherence. But this is all sort of in the research realm. What's become unique in this very unusual time is you've seen rapid virtualization exceptionally quickly. And what that's meant is, as Alex sort of mentioned, there's been a bit of a free-for-all in terms of how this is being done. So that while there have been models like that have worked in technologies, Akira and others have been around for a long time, the vast majority in Ontario and I think in other provinces where this has been enabled have been sort of like, okay, we've created billing codes, so kind of go do it, and let's hope it works out. And so we're actively going to be engaged in trying to understand what the impact of that has meant, not so that we go back to the way it was, but so that we can figure out what's best practice, and then how do we optimize that best practice. And then, so that would be the first thing. And the second, which I think is sort of important to think about, is part of it as a doctor is starting to ask the question about, if this is a tool, when is the right time to use the tool? And what's the right tool for the right job? So here's just a simple clinical scenario. So you're a family doctor who has a patient who you suspect has COVID, okay? They're saying they have a fever, chills, and a bit of shortness of breath. But you can't examine that patient. You're seeing them over video or you're doing a phone visit. And the challenge now is, okay, so what do you do next? How do you assess that patient if they're not in front of you to examine their lungs, to listen to their lungs, to see if there's impact of COVID on their lungs? Do you send them for a chest x-ray? Do you send them to the assessment center to just get a swab? Or do you think that they're sick enough that they actually require an emergency room visit? So this is going to be some of the stuff that we have to work out. In which types of conditions is, phone appropriate? Is video appropriate? Is text appropriate? And when do you actually need to bring somebody in? And then what are the diagnostic tools, whether they be wearables, they be x-rays, blood work, that sort of thing, that then needs to be utilized to augment that? And I'm sure there are many companies who have great tools that we can think about, but as physicians, we have to put all the pieces together to create really interesting clinical pathways to manage these patients to ensure that we're doing the right thing.
Okay, so Dr. Greenhill, if I can tee you up there, I just want to say one of the headwinds in the face of virtual care has been the concept of the episodic nature that some virtual care models can represent and the potential lack for continuity of care. Can you just dig into that for a minute or two for us, and then we'll move on to payers? Muted.
So the earlier point of quality, it depends on how the technology is used. And so I often say a cell phone can be used to compliment someone or insult them, either by text, email, or phone, but it's the end user who determines what you do with this device. And sort of the regulators are catching up to this flow, and the medical associations, the College of Physicians is trying hard to create guidance around this massive influx of, the 10% of doctors now becoming 90% who use virtual, and creating new social norms and etiquette around what's appropriate within the scopes of practice, and helping people configure this. So there'll be lessons learned. Hopefully people remember that first do no harm. And so if they can't make a diagnosis on video, their duty of care is to direct people to an in-person encounter at the right place. And all of that is we're figuring this piece out. What I'm excited about is the ability of some of these video analyses that tell you the moment the patient comes online, they've already measured respiratory rate, blood pressure, heart rate, temperature, inferred through an AI-like algorithm. So you can start doing some of those screening before you even say anything, whether or not the patient has submitted it. And it sounds like science fiction, but I've actually seen it in use in some other countries, for example, in Israel. The question about the episodic care versus continuity is the reality of what Dan was describing is that virtual mirrors in many ways what happens in real life. And the ultimate goal being every physician gets to follow up on the patient that they already know is not always feasible. So the need for walk-in clinics or emergency room exists in real life, and that equivalent needs to also exist in the virtual space because we need to ensure that patients have timely access to care and no adverse outcomes happen. How these clinics are set up and how much information they get from the patient before they help them is the same quality control issue with walk-in clinics in real life. And so they're professional norms. Not everyone follows them, but there's a way of looking into the virtual space and holding some of these sort of independent, the Walmart, standard of in 3 minutes you have an answer, I think drives some of those poor sort of perceptions of episodic encounters. They are appropriate, but we still have a duty to properly assess the patient and determine, using all of the knowledge that we have, whether or not we can recommend the kind of solution that they are seeking from us on that day. And then the opportunity to send that information back to someone else that is following the patient is great. But we still need to remember the large percentage of Canadians that unfortunately does not have a primary care provider, and the same difficulty persists.
Okay, thank you. So with about 10 minutes to go in our discussion, then we're going to take some questions. We're now going to move on to the payer landscape, thinking particularly about our audience. And Dan, this first one is to you. So with the single payer, that is our provincial single payers, coming online to virtual care, particularly over the last 6 or 8 weeks with speed, that puts insurers and employers and perhaps even individuals in a different place. I'm wondering if we can start with comments from you on the evolution of the payer landscape.
Sure. So it's actually an interesting choice of words you used there to pose the question, which you said single payer. And as I think all of us know, that there's a single payer for certain services as delineated within the schedule of benefits, which is very long and exhaustive. And it can be very difficult to understand. So yes, there's a single payer for medically necessary services. And so our sense is you'll probably have multiple payers for virtual care services, very similar to what you have today, where you have corporates and plan sponsors who pay right now billions and billions of dollars of healthcare costs to augment what is publicly available, because frankly, their objectives are different than the objectives of a public health agency, which I think everybody understands. They think about the employee wellness. They think about ROI in terms of whether it's drug costs or absenteeism. And they think about how they want to be perceived by their employees as a provider of healthcare. So I don't think the increase of a payer model in virtual care will change the dynamics of how people access and have accessibility to healthcare. I don't think it's any different than it has been in the past. And Michael, I know you're based in BC, and BC's had a fee code there for years. I'm not sure if we've not seen any difference between plan sponsors in BC versus other provinces of whether they're going to pick up virtual care. We've again, in the last 90 days, since other provinces have picked up fee codes, we again have not seen any difference in terms of the demand for the Acura services. And, there's a whole litany of things, which is really interesting to think about the services that virtual care can provide. A couple small ones, as I mentioned earlier, about 50% of our consultations are via text. Well, gosh, that is fantastic for the provider, fantastic for the patient. And when's the reimbursement going to come for text-based reimbursement for providers? I think there's something in BC. It's always a little bit more difficult for the provincial health bodies to regulate stuff. And then the other, frankly, thing which I think is fantastic is on the virtual care side, having the flexibility of a plan sponsor who wants to design programs for their employees, whether it's just general access to primary care or mental health or chronic disease management. The virtual care platform allows you actually to access a full healthcare team, not just a physician. They can access a dietitian, a nurse practitioner, a specialist, a GP, a mental health counselor, all within one platform. Very hard to figure out the reimbursement model for that within a public payer. And as you said, the public payer is very good for very specific items on a schedule of benefits. Providing a larger platform of care, I think it's a little bit more difficult in today's world to do that. And just as I'll leave with one example is in the last couple of months, as you can imagine, very high utilization of our primary care service. Our mental health services have probably gone up somewhere in the order of 7 to 8 times what they were pre-COVID in terms of access to our mental health services. A lot of those wouldn't have been reimbursed by the public health agencies, but they would be reimbursed by corporations through the third-party benefits. So when you think about a service like that, fantastic that people could now access mental health in a little bit less of a stigmatized way through a virtual care service. And that might be a service that the public health authorities may not reimburse as quickly as corporations can do. And corporations will want to do that for the health and wellness of their employees.
Okay, interesting. Lots there. I'm watching time. So, Sasha, this one's to you. I'll put you in a time box of a minute or a minute and a half if I can.
Sure.
Thinking fee-for-service versus fee-for-value at the single payer level, is there friction in one of those models more so than the other in terms of virtualization?
Well, it becomes a really ideological question, right? I mean, fee-for-service does what it's designed to do, which is increase utilization. And I think, for getting a model like this off the ground, adding fee codes was the easiest way in order to get physicians who are already predominantly engaged in fee-for-service to adopt them. The question around fee-for-value is probably a more sustainable strategy in the long run because, again, it encourages a multi-channel, a right person for right technology, right time type approach. The challenge, again, just one simple example is, because in the U.S. video has always been incented, video has always been the predominant modality of communication, even though, as Dan had mentioned, efficiency gains are predominantly in texting and asynchronous messaging. Video doesn't create efficiency gains. And so, but because of the incentive structures, most of the engagement is in video. So if you really want to get value, you need to be thinking about changing the financial models. That may not be the right thing for this time, but certainly as we move to virtual being permanent, we're probably going to have to think about how it's built.
Okay, need to go back to Dan for one more on the payers here. We've seen substantial deals over the last many weeks or a little bit before that between insurers and the virtual care providers in Canada, meaning there's been some very quick procurement. Can I get you to provide commentary on what you think that does to the employer market? Do the large employers turn to their insurance providers and insist that virtual care is within the basket of goods offered by them? Or do you think there continues to be a bifurcation in that market?
Yeah, no, it's a good question. I think the interesting thing is the market is changing dynamically. Plan sponsors, whether you break it down by type of industry, size of employer, frankly, where they're located, and frankly, their spend on health and wellness, that will change the calculation for them as to whether they want to embed that service into their insurance or whether they would like to have an endorsed service and actively purchase that service. I think the answer is kind of TBD over the next kind of 6 to 9 months as to see where the market goes. One thing we have found is plan sponsors who actively choose to provide virtual care. What we have found is they're more married to the solution. They want it to work. They want their employees to use the service. They have a feeling that they want their employees to embrace virtual care, and they actively make it possible and available for them. And so they spend a lot more time on awareness. So that's one thing that we have found. But I think it's probably too early to figure out exactly the different distribution channels. I think what's really interesting is it's now created a situation where the virtual care is now at the top of mind for a lot of different providers in the channel and also with the plan sponsors. And it frankly allows each of the plan sponsors to make their own independent decision as to what they want to do. So it's raised the conversation and the topic, and then the plan sponsors, of course, are totally free to do what they want to do.
Okay, so to a closing question, we're going to go around the horn, Alex, Sasha, Dan, in this order. Let's imagine 2 to 3 years from now. Please give our audience your opinion on the state of the virtual care market in Canada, and maybe if you can touch on one or both of the following questions. What will have happened and what won't have happened? Alex, if you can, in a minute, minute and a half, please.
Well, I think that we will see, to Dan's point, we're 10 years ahead of where we would have been had COVID not happened. We will see telehealth broadly defined as anything not synchronous in time and place, to pick up on Sasha's point, becoming much more prevalent, and the in-person encounter being one option, but not the main or the first option. And I think that the interesting point that was just discussed about plans and sort of futures is, I think we're right now paying a huge price overall on delays in the system. And so the ability to use virtual to speed up certain things that otherwise become chronic or complicated, or give people the right access to the right person at the right moment to reduce the burden on them as a patient becomes key. And as we're seeking some of this efficiency and whatnot, is we shouldn't forget the importance of the relationship, trust, experience. In the U.S., they are rated on customer experience or patient satisfaction. And here we are too focused on the clinical outcome, and we forget the importance of a human at the end of the day, finding that they are reassured and that they are confident in the health care that they've received, whether it's from a one-time encounter or someone who follows them on a regular basis. I think virtual healthcare is here to stay, and some of these initial issues will get sorted out in the next 18 months.
Thank you. Sasha?
So I think probably 50% of our care now will be virtualized. I can see care redesign taking into account what we would call the cost of contact, or the cost of a physical interaction with patients, and that will matter as much for providers as it will for the patients themselves and their convenience. I think you're going to see entire clinical areas be redesigned. So you could imagine, for example, a surgical journey where the preoperative and postoperative follow-up will be completely virtualized, and really the patient will come in for surgery and leave. I think certain specialties like mental health could become completely virtualized, but there'll still be a substantial amount of in-person care. But as sort of alluded to, by the other panelists, I think the real question for us will be, what needs to stay in person, and how do we create a care pathway that integrates various parts of virtual care with in-person care. I think what will not change is the payment system. So I think we're going to do this on a hodgepodge of billing fee-for-service, and I think probably some other stipends or sessional fees that will still hew to a fee-for-service model, except in primary care where there is capitation. And probably that will mean that there'll be some loss of income in certain areas by doctors as they shift to a new reality. So I think you are going to see, though, a general hew to the fee-for-service system.
Very, very interesting. That cost of contact, of course, notable across industries right now as we look at rebooting the country and our economies. Dan, last word to you in a minute and a half, and then we'll have 10 minutes for questions, please.
Sure. Great. So I think penetration, at least for primary virtual care, if it's, probably in the 10, 15, maybe 20% range right now, it'll be well above 60, 70% for sure. People will have finally their first virtual care experience, and they'll love it. That will lead into what we call the digital medical home. You then you come to your phone for all of your first access to your virtual care, whether it's primary care, mental health care, or potentially care navigation. That becomes your medical home, where historically it's been your physical medical home. So I think those two things will occur. My hope, I'll throw one in there too, my hope is that we're integrated a lot more with the Ontario health teams in Ontario. I do think that there will definitely be much further integration into EMRs, into pharmacy systems, into your electronic health record. So there will definitely be much more of an ecosystem. And unfortunately, Sasha took my point, which was I don't think value-based care is going to be occurring in the next 5 to 8 years. It's unfortunate. I think that's a real opportunity. I would encourage health regulators to potentially try some of those models to see whether it would work or not. And if it doesn't work, let's just reiterate and try something else again. But I do believe there'll be deep integration within all aspects of healthcare, but it'll just more be fee-for-service and less of a capitated model.
Okay, thank you, all three of you, for those closing comments. And now, Jason, we're back in your hands for some Q&A for the next 10 minutes, please.
Thank you, Michael, and to the panelists for that informative, thoughtful, and really well-rounded discussion. Ladies and gentlemen on the line, it's time for our Q&A. There have been some questions that came in during the panel discussion, but if you haven't already done so and wish to ask a question, please follow the instructions there on the screen, and we'll do our best to cover them all. Michael, there were a couple of questions that came in on the future and on the payment model, which were addressed through the discussion, so well done navigating. We have some other ones that came in, starting with here, and I'll let you kind of direct. Can you chat about the current status of one-to-many versus one-to-one in terms of AI, bots, et cetera?
Very interesting. I'm going to ask Alex to take a crack at that first, because I know it's something she knows well. Alex, your thoughts on one-to-one versus one-to-many in the role of predictive technologies in virtualization of care? Muted.
I'm a huge fan of what's been happening with bots and AI. There is a lot of efforts that are described as artificial intelligence or chatbots, but they're essentially limited, if this and that kind of responsive tools. But some of the more innovative companies who are putting together real intelligence behind the assessments are doing essentially like a nicer version of Dr. House, is helping me as a clinician think of some sort of obscure condition that otherwise I wouldn't be top of my list, and accelerating that diagnostic process. Patients' acceptance of these tools is incredibly high. The scary part for me as a clinician is in the last 6 weeks with COVID, somebody did a deep dive into it, and we've seen 600 times the downloads of mental health apps that are self-serve, sort of chatbot-based conversational tools, and only 3% of these tools had any scientific backing. And sort of it's too easy nowadays for anyone to throw together something and say this is a well-intentioned sort of effort, and miss the fact that we still have a duty for evidence behind what we're trying to accomplish. And so there's a few efforts that are university-driven, clinical teams that are serious behind what they're doing. And I think that these tools will become more prevalent and blend in or augment what humans can do in the system to provide more support for people who need it around the clock.
Thank you. Back to you, Jason, for the next one.
Absolutely. How safe is virtual care in terms of cybersecurity and patient confidentiality?
I'm going to go to Dan on that one. Dan, I'm sure that's something that you get asked on the procurement side. Can you make some comments in general, and then perhaps maybe touch on the Acura stack in particular?
Sure. One of the jokes that we talk about is people want to have they want to have as great a security as you would have in the world of the hospitals. And of course you joke and you say, well, hospitals don't exactly provide the most secure and private access to data. So as you can imagine, Acura being a very recent technology and being purchased by some of the largest employers in the country, the technical security and privacy review not just your technology overview, but also just your process overview. We're, of course, SOC 2 compliant, which is the highest level of process security and automation. So the standards they have are unrelenting. Probably the largest part of our RFP process in terms of working with some of the largest companies is on the privacy and security side of things. And with the recent technology, we're extremely confident in our technology, privacy, and security capabilities. It's definitely something that as we provide more linkages to other technologies, that's probably where the larger question is going to be, which is when you connect in with EMRs and then the provincial registries and then access into the imaging registries and labs. I think that's where it'll become a little bit more apparent to see what are the standards required by industry to ensure that confidentiality and privacy and security is at its highest. So I think that's probably where they'll probably be spending a lot more time going forward, because we want to provide these linkages to provide the ecosystem, and I think that's going to be the biggest focus.
Okay, thank you. Back to you, Jason.
Michael, how does the patient-doctor relationship change when they work with a virtual care doctor versus their primary family doctor? There's been 3 or 4 questions along that line here, worried about backlash, that sort of thing. So probably best to prioritize this one.
Good, thank you. Yes, I noticed a few of those in the chat. So let me first go to Sasha with this, and then I know Alex will have something to add. So let's have a few comments around the concept of a primary care physician, someone who is rostered perhaps, and then what the virtual care landscape would look like and whether there's any channel conflict, if that's the right term. Sasha?
Yeah, I don't think it has to be an either or. I think ideally virtual care integrates as critical tools in comprehensive primary care and in specialty care. So I, email with my patients. I, speak to them on the phone. We do video visits. And the reality is I think patients in general prefer that level of comprehensive care. So I think if you do it correctly, in fact, and you integrate it as part of the patient journey, it can actually enhance trust. Because rather than, getting a fax as we would from your family doctor that, as a specialist, that there's something wrong with the patient, patients will just email me or call the office, or we'll get on a video call, and they feel much more integrated and much more in trusting that the care experience is working for them. I think the danger that we have to be very careful about is that virtual care doesn't fragment our care further. So it should bring us together. But if we have care silos and things don't connect, what will then happen is just exacerbate what we have often right now, which is where, some people go to different portals or channels that don't necessarily connect back to their primary care physician or their treating physician. So, I don't necessarily have I think virtual walk-ins, virtual physicians can play a very important role, but we have to figure out a way that the pieces connect. Otherwise, we're going to end up in fragmentation. But I think in general, these tools can actually be very positive for the primary care and physician relationship.
So, Alex, then what would your advice be to a patient and to a GP in around these issues? What words of wisdom would you provide to them around this issue?
I mean, what's really interesting is the opportunity for virtual to strengthen the primary care by actually creating virtual visits between primary physicians and specialists. And so how many consults can I avoid if I can just jump into what's known as a corridor consultation and talk to a cardiologist or a specialist as to what and how I should do and manage. And in BC, we've had the codes to pay the doctor, both doctors, and facilitate that connection. And that may become a huge game changer. I think that the average patient doesn't quite understand the difference. To them, a doctor is a doctor is a doctor. So I see a lot more people saying it's convenient for me to just jump into the local clinic, and I don't quite understand the value of continuity. Patients who have chronic disease, which is about a third of the population, they get it. But typically, the average healthy adult who had a sprained ankle sees that there's no huge advantage to having the same person providing care. And so a little bit of patient education can go a long way on this one.
Thank you. Jason, we'll pass it back to you for a wrap, and my thanks to the panelists. I trust we hit the mark of putting on an interesting discussion today. Jason.
Yeah, thank you, Michael, and to our distinguished panelists today. Great topics and great discussion. To those on the line here, we hope you found this time together and the content valuable. As always, it was certainly an honor for us to be able to deliver this to you. As with other past webinars in this series, we'll be able to host a recording of this webinar on our Health Benefits Hub. So subscribe to the mailing list to get notified for that. And as indicated at the onset, we'll be sharing a survey with you shortly. We ask that you please participate, fill it out, tell us how we did. As I indicated, we're always looking for ways to improve, and your experience matters. Lastly, from a CE point of view, we'll be processing the attendee list that joined here today, so expect to hear back from us in a couple of weeks' time. And rounding it out, I'd like to say thank you to our presenters, to Michael as our facilitator, and to our sponsors and insurance partners for helping make this possible. In the coming weeks, we have 2 more webinars remaining for our virtual conference. We have the promise and potential of type 2 diabetes reversal by Dr. Brendan Byrne next week on June 2nd. And we have National Pharmacare in the Age of COVID-19 and Beyond, presented by former Ontario Deputy Minister of Health, Dr. Bob Bell, and Michelle McLean, and that will be on June 9th. So please make sure to register if you haven't done so already. We had a great turnout today. Would love to see you for those sessions as well. Lastly, just want to say thank you for your attendance today. Have a wonderful afternoon. Stay safe, everyone, and looking forward to hosting you again next week. Thanks again.
Thank you.